Hello, everyone. On behalf of the Crohn's and Colitis Foundation of America, welcome and thank you all for attending tonight's webinar on colorectal cancer, Understanding the Risk and Prevention. My name is Catherine Soto, National Education Manager at CCFA. This program is supported by the Maxine and Jack Zarrow Family Foundation. Additional support is provided through CCFA's annual giving programs and donors. If you have any technical difficulties during the program, please dial audience support at the number you see on the left side of your screen. If you prefer to listen to the program via phone, you can also find the participant dial-in number also located on the left. After the presentation, we will open up the program for your questions. We will take as many questions as time allows from webcast participants. If we are not able to take your question, our IBD Help Center can be reached Monday through Friday, 9 a.m. to 5 p.m. Eastern Time by calling 888-694-8872. Upon exiting today's program, you will be prompted to complete a brief program survey. We ask that you please take a few moments to provide your responses, as your feedback is extremely important to us as we plan for future educational activities. I now have the pleasure of introducing our speakers for tonight's program. Dr. Carly Osk is an adult gastroenterologist at Swedish Medical Center in Seattle, Washington, where she works as medical director of their Inflammatory Bowel Disease Program. She is also a member of CCFA's Patient Education Committee of the National Scientific Advisory Committee. Dr. Ann Flynn is Assistant Professor of Medicine in the Division of Gastroenterology and Hepatology at the University of Utah. She's an attending physician in the University of Utah's Inflammatory Bowel Disease Program. Dr. Flynn's clinical interests include comprehensive care for patients with inflammatory bowel diseases, including Crohn's disease and ulcerative colitis, and treatment of recurrent C. difficile infection. Dr. Blair Fenimore is an assistant professor of medicine in the Division of Gastroenterology and Hepatology at the University of Colorado. As an attending physician in the University of Colorado's Crohn's and Colitis Center, Dr. Fenimore's clinical interests are focused on the diagnosis and multidisciplinary management of inflammatory bowel disease of the GI tract, including Crohn's and ulcerative colitis. Dr. Fenimore's research interests focus on inter-organ crosstalk mechanisms, specifically in understanding inflammatory crosstalk between the liver and intestine in primary sclerosing cholangitis-associated inflammatory bowel disease. Thank you for the three of you for joining today's program and presenting this wonderful information. I will now have the pleasure of turning the program over to Dr. Carly Osk.
Thank you, Kat. I'm excited to be a part of this important program that the Crohn's and Colitis Foundation of America has developed to help you learn more about the issues of colorectal cancer and inflammatory bowel disease. After today, you should be able to list the risk factors for colorectal cancer in people with ulcerative colitis or Crohn's disease, identify the symptoms of colorectal cancer, describe guidelines of screening recommendations to prevent colorectal cancer, and list ways to reduce your risk of colorectal cancer. To learn more about colorectal cancer, we should first take a step back and look at the anatomy of the large intestine. If you think of where your food passes through your digestive system, the large intestine is the last part of this system. It passes through your esophagus, stomach, small intestine, and then the large intestine. The first several feet of the large intestine is the colon, and the last 6 inches is the rectum. The colon and the rectum are made up of many different types of cells, and normally your body cells divide in a regular, orderly fashion to replace themselves when new cells are needed. However, sometimes cells can divide and produce new cells when they are not needed. and that can develop into a growth of tissue. And any growth of tissue in the body is called a tumor. Tumors can be benign or not cancerous, or they can be malignant or cancerous. And tumors become malignant when the cells are irregular enough to grow outside of the area where they should be growing. And in the colon, that would be cells that are able to spread outside of the intestinal wall or to other parts of the body. There is an increased risk between inflammatory bowel disease and colorectal cancer. There's a well-established link between the amount of inflammation in the large intestine and the risk of colorectal cancer. So this would include people who have ulcerative colitis involving part or all of their colon, and people who have Crohn's disease when the inflammation of Crohn's disease involves the colon. As you know, not everyone with Crohn's disease has colon inflammation. Why does inflammation increase the risk of colon cancer? Really ties back to the cell turnover that happens. Because of the inflammation of Crohn's disease and ulcerative colitis, cells are continually turning over, and the higher rate of cell turnover can increase the risk of cell irregularities or cell mutations, which then drive the increased risk of colon cancer. But there are several pieces of good news on this subject. The majority of people who have Crohn's disease or ulcerative colitis are not going to develop colorectal cancer. And regular routine examination with a colonoscopy can find precancerous tissue and early cancers when they are still treatable. Many precancerous lesions can be treated or removed during a colonoscopy, therefore preventing cancer and avoiding surgery. And all this comes back to the theme that regular colonoscopy screening is crucial to the prevention of colon cancer. There are several risk factors among people with inflammatory bowel disease that have been tied to the development of colorectal cancer. First, the length of time you've had your disease increases the risk of colon cancer. That risk for colorectal cancer does not start to increase until about 8 years after inflammatory bowel disease has been diagnosed. In addition, how much of the colon or how severe the inflammation is in the colon increases the risk of colon cancer. For example, if your entire colon is affected, you have a higher risk of colon cancer than if a portion of your colon is inflamed. There's a condition called primary sclerosing cholangitis that causes inflammation or scarring in the bile ducts. It can be seen in some people who have ulcerative colitis or Crohn's disease. Those people in particular have a higher risk of colon cancer, and that risk increases even earlier than the 8 years after diagnosis of their inflammatory bowel disease. Whether you have inflammatory bowel disease or not, a family history of colorectal cancer increases your risk of colorectal cancer, and that's particularly strong in people who have a first-degree relative who's under the age of 60 when they're diagnosed with colorectal cancer. And most of the time, colorectal cancer starts as these non-cancerous growths on the lining of the colon, and those are called polyps. In particular, a polyp type called an adenoma is the kind that has a potential to continue to grow and develop into colorectal cancer. And you've probably heard of these polyps because polyps are very common. Most of them do not develop into colorectal cancer. Most of them don't cause any symptoms. However, we know that they have the potential to continue to divide and grow, become more irregular, and ultimately some of them can develop into colorectal cancer. This growth and dividing process often takes years, more than 10 years, to develop into a colorectal cancer. However, removing these polyps through a colonoscopy can prevent most colorectal cancers. And this is the reason why routine screening colonoscopy is recommended even among people with no symptoms in the United States. However, in patients with ulcerative colitis or Crohn's disease, sometimes colorectal cancer can develop a little bit differently. Sometimes it's preceded by these polyps that can be removed to prevent that risk. But sometimes it arises in an area of flat cell changes that can sometimes be difficult to see. And those flat cell changes are called dysplasia. In people with inflammatory bowel disease, dysplasia might develop in more than one location of their colon. It might occur at a younger age than it would be seen in someone without inflammatory bowel disease. And it may progress more quickly, even within 1 to 3 years, from dysplasia to a colon cancer. Therefore, compared to the average population, people with inflammatory bowel disease require earlier and more frequent colonoscopies for the prevention of colorectal cancer. Another key to identifying colorectal cancer early is paying attention to the body and learning more about the symptoms of colorectal cancer. Sometimes colorectal cancer causes no symptoms, and it may vary depending on the location of the colorectal cancer in the large intestine. Some of these symptoms may also mimic the normal symptoms of inflammatory bowel disease. However, if you are noticing any of these changes and those changes persist for longer than several days, it's wise to talk more to your provider about your concerns. Some of the symptoms of colorectal cancer can be changes in your bowel habits, such as diarrhea or constipation, changes in the size or the frequency of bowel movements, having blood in your stool, having discomfort in your abdomen, cramping, losing weight, or feeling like your bowel does not completely empty. Again, if you have any concerns at all, the best next step is to talk to your primary GI provider and express your concerns.
Thank you, Dr. Ock. Surveillance and prevention of colorectal cancer are key. When discussing colorectal cancer, it's important to understand a few definitions. Screening refers to testing that's done before symptoms develop. We use the word surveillance to describe exams that are done after the first screening. Dysplasia refers to precancerous changes in the tissue. The goals of surveillance for colorectal cancer are to find and completely remove precancerous tissue or dysplasia from the colon to prevent colon cancer from developing. We want to detect cancerous lesions early when they can be removed and treated and prevent death from colorectal cancer. Colorectal cancer screening and surveillance are important in Crohn's disease and ulcerative colitis. In ulcerative colitis, the risk of colorectal cancer begins to increase after 8 years of disease. We recommend that you have a colonoscopy when you've had disease for 8 years. At that time, biopsies will be taken throughout your colon to understand how extensive that inflammation is within your colon. And based on these findings, your doctor will make recommendations regarding future surveillance procedures. If you have Crohn's disease that's involved your colon, inflammation involving the colon increases your risk of developing colorectal cancer, and you should also undergo surveillance procedures. After 8 years of disease, we recommend that a colonoscopy be performed, and your doctor will make recommendations about further surveillance. If you have a family history of colorectal cancer, you're at higher risk for developing colorectal cancer, and you should be surveyed more closely. If you have a personal history of colon polyps or precancerous lesions in the colon, you should also be surveyed more closely. If you have an ileostomy in place, but a portion of your colon remains, such as a Hartmann pouch, this area should be surveyed for cancerous or precancerous lesions. Any colon tissue remaining should be surveyed to be sure that cancer or precancerous lesions have not developed. Primary sclerosing cholangitis is associated with an increased risk of developing colorectal cancer. If you've been diagnosed with primary sclerosing cholangitis, or PSC, you should have a colonoscopy at the time of diagnosis, and a colonoscopy should be done every year for surveillance to look for precancerous lesions or cancer within the colon. Colonoscopy is the preferred test for colorectal cancer screening and surveillance. We recommend that a colonoscopy be done 8 years after the diagnosis of inflammatory bowel disease, and a repeat colonoscopy will be done for surveillance every 1 to 2 years thereafter. The timing of the surveillance colonoscopies depends on what's seen during your colonoscopy, as well as your individual risk factors for colorectal cancer, such as a personal history of polyps, a family history of colorectal cancer, or severe inflammation in the past. Primary sclerosing cholangitis, as I mentioned, is associated with a higher risk for colorectal cancer, and screening starts immediately at the time of diagnosis, and surveillance colonoscopies should be done every year to look for cancer or precancerous changes. During a colonoscopy, a colonoscope is used, which is a long, flexible tube with a light and a camera on the end. The colonoscope is inserted into the rectum and advanced through the colon to the end of the small intestine. It's then pulled back, and the lining of the colon is carefully examined. A video image is transmitted to a large screen. Air and water are passed through the scope to inflate the colon and wash the lining of the colon. Suction through the colon scope can help to clean away residual fluid. Tiny tools can be passed through the scope to take biopsies and to remove polyps or concerning lesions. When you come for your colonoscopy, an IV line will be placed. In most cases, you'll receive a sedative medication, which will make you sleepy and comfortable throughout the procedure. Your blood pressure, heart rate, and breathing will be carefully monitored throughout the exam. And for most patients, there'll be no discomfort or minimal discomfort like gas and bloating after the procedure, which quickly goes away within 10 to 15 minutes. Screening and surveillance colonoscopy are best done when Crohn's or ulcerative colitis is in remission, meaning inflammation is well controlled. Inflammation can cause changes in color and texture in the colon lining, making it difficult to differentiate precancerous or early cancerous lesions from areas of inflammation. When biopsies are taken in inflamed areas of the colon, it can be difficult to differentiate whether changes are precancerous or related to inflammation. In some cases, surveillance may be required even when your disease is active, and this will be determined by your doctor. A good bowel preparation is extremely important to a high-quality colonoscopy screening or surveillance examination. The colon should be extremely clean to have the best examination possible. Polyps, flat lesions, early cancers can be subtle or difficult to see during the procedure. If there's areas of stool that cannot be washed from the walls of the colon, small or concerning areas could be missed during your procedure. What can you do to have the best bowel preparation possible? You should review your bowel prep instructions 1 to 2 weeks in advance so that any questions can be answered by your doctor's office. In most cases, you'll follow a low-residue diet or a clear liquid diet the day before your examination. To clean out your colon, you'll take in an oral liquid solution. There are several different liquid solutions available, and your doctor will help you to choose which one is right for you. In most cases, you'll take the bowel preparation as a split prep, meaning 2 doses. You'll take half the solution the evening before the colonoscopy, and the remainder of the solution, usually 4 to 6 hours before the colonoscopy procedure. Split bowel preparations provide the best possible preparation. They're better tolerated, and they give better cleansing of the bowel walls. When your bowel prep is completed, your stools should look clear. They should look like urine with no solid matter. If you're concerned that your bowel preparation may not be adequate, you should contact your doctor's office. If you're having trouble finishing the bowel preparation, you may consider refrigerating the solution. Sometimes it's easier to tolerate a cold solution. You may try drinking the bowel preparation through a straw. You could take a break and walk around, then go back to the bowel prep solution to see if it's better tolerated. If you're having trouble with nausea or vomiting while taking your bowel preparation, you should call your doctor's office. We can use tools during colonoscopy to improve the quality of our examination and help us to identify cancer or precancerous lesions. A blue dye can be sprayed over the lining of the colon. This blue dye pools into the crevices of the colon lining to help with detection of subtle lesions and to find borders of concerning areas in your colon. This technique is called chromoendoscopy. When we apply this blue dye spray during your colonoscopy, it helps us to outline flat lesions or early cancers, and it helps to draw your doctor's eye to areas of concern in your colon that can be evaluated further. Chromoendoscopy is best done with an excellent bowel preparation. I use chromoendoscopy when doing dysplasia surveillance in my patients, and when this blue dye mixes with leftover stool in the colon lining, the dye spray turns green and it becomes very difficult to identify areas of concern. You want your colon to be as clean as possible so that all areas can be fully evaluated and visualized well during the procedure. Chromoendoscopy is best used in a colon that is not inflamed. If there's active inflammation during your procedure, it might not be possible to use chromoendoscopy during the exam. Chromoendoscopy can help to identify early or flat polyps, which can be biopsied or possibly removed during the colonoscopy examination. We have some images below. If you look at the image in the center, this is a concerning lesion before the blue dye spray is applied. You can see areas of uneven redness, but it's very hard to identify the borders of this lesion. If you look at the image to the left, chromoendoscopy, or that blue dye spray, has been applied. And you can much more easily see the borders of this lesion so that it can be biopsied or resected during the exam. If you look at the image to the right, this is the same area of the colon which was photographed 1 year earlier during a colonoscopy surveillance exam. Without the use of the blue dye spray, it was very hard to recognize that this was a concerning lesion. This lesion was missed during that examination. We have promising study results indicating that chromoendoscopy helps us to identify concerning areas in the colon during surveillance and screening examinations. The number of patients with dysplasia identified during a colonoscopy increased 1.8 times when chromoendoscopy was used. The number of dysplastic lesions discovered during examinations increased 1.9 times with use of chromoendoscopy compared with colonoscopy alone. The number of patients with visible dysplasia, areas that could be biopsied and potentially removed during a colonoscopy procedure, increased 2.3 times when chromoendoscopy was used. The number of visible dysplastic lesions seen during a colonoscopy increased 2.1 times with use of chromoendoscopy compared with colonoscopy alone. We now have high-definition colonoscopy scopes, processors, and screens, which help with increasing the resolution of images during colonoscopy procedures. It's important to understand that a colonoscopy examination is different when your doctor is evaluating disease activity versus evaluating for dysplasia or colorectal cancer. A colonoscopy that's done to evaluate symptoms or to determine whether symptoms are due to active inflammation in the colon or to look for inflammation in your colon. During these procedures, very often your disease will be active during the colonoscopy procedure. Your doctor may take biopsies to check for infection or to look for microscopic disease activity, but overall, a small number of biopsies may be taken. And in this situation, chromoendoscopy dye spray typically would not be used. When a colonoscopy is done for colorectal cancer screening or surveillance, the goal of the procedure is to look for cancer or precancerous changes. This exam is best done when your colon is in remission, meaning that inflammation is controlled to the maximal extent possible. Your doctor will often take several biopsies to evaluate many areas of the colon and identify any concerning lesions. And in this situation, very often chromoendoscopy would be used to increase the contrast as your doctor looks through the walls of your colon and to define borders of any concerning lesions. This chromoendoscopy dye spray would be used to help your doctor to remove concerning lesions and ensure that areas of concern are removed completely during your examination whenever possible. Now I'd like to pass the program to Dr. Blair Fenimore.
Thank you, Dr. Flynn. So we've had a lot of discussion on the importance of colonoscopy surveillance to detect dysplasia in the colon. But what exactly is dysplasia? Well, dysplasia refers to abnormal cell growth within the colon, and while dysplasia itself is not cancer, it can ultimately develop into cancer in some cases. Therefore, identifying dysplasia is a prime opportunity to offer effective treatment before cancer even develops. There are various degrees of dysplasia, and the specific degree is determined by looking at a sample of the tissue under a microscope. With each step up the ladder from indefinite to low-grade dysplasia to high-grade dysplasia, the risk of those cells developing into cancer continues to increase. Thus, while all dysplasia is important, the finding of high-grade dysplasia carries the highest risk for developing cancer. As mentioned, because dysplasia can develop into cancer, it should be removed and offers a prime opportunity to stop the development of cancer in its tracks. When dysplasia is detected on colonoscopy, the endoscopist will determine whether it can safely and completely be removed by colonoscopy or whether it requires surgical removal. This decision on endoscopic versus surgical management depends on a variety of factors, including the degree of dysplasia, low versus high grade, its shape, is it polypoid like a mushroom or is it flat and spreading like a carpet, its size, smaller lesions are clearly easier to remove than larger lesions, and its visibility, can the borders of the abnormal tissue be easily identified, and is it in a location of the colon that makes removal through a colonoscope more feasible. Ideally, dysplasia can be identified and adequately treated before it turns into cancer. However, the good news is that even if colon cancer does develop, it is highly treatable with a greater than 90% survival rate if detected in its earliest stages, particularly before it's had a chance to spread beyond the colon. Unfortunately, cancer itself cannot be removed by colonoscopy. However, as with dysplasia, the correct treatment depends on a variety of factors such as tumor size, location, and extent, including whether it remains confined within the colon or is spread outside of the colon to other organs. Cancer treatment decisions are made through consultation with both surgeons and medical oncologists. Surgery to remove the tumor and surrounding tissue is very common. However, patients may also require chemotherapy or radiation therapy, particularly if the cancer is spread beyond the colon. And often, patients may be treated with both surgery and chemo or radiation therapy. Now, as before, even if cancer does develop, it remains highly treatable if detected in its earliest stages. Undergoing regular surveillance colonoscopy can detect cancer at earlier and more treatable stages and may decrease the risk of death from cancer in those patients who are diagnosed. Thus, early detection and regular screening colonoscopies are vital to managing and preventing colon cancer. Even though your risk of colon cancer with ulcerative colitis or Crohn's disease is increased, there are multiple ways to help reduce this risk. These include managing your disease inflammation effectively, undergoing routine surveillance colonoscopies, importantly even if you're feeling well, maintaining a healthy lifestyle, and in some cases using various medications or supplements as chemoprevention, which we'll discuss later, to help decrease colon cancer risk. While no intervention will completely alleviate the risk of colon cancer in people with IBD, these measures can help minimize the risk as much as possible. There have been a variety of lifestyle factors that have been associated with an increased risk of colon cancer in both the general population as well as in IBD, and these include obesity, sedentary behavior, and diets high in fat and red or processed meats. While completely avoiding certain foods is not realistic or even necessary, maintaining a generally healthy lifestyle with normal body weight, regular exercise, and a healthy, well-balanced diet is important not only for overall health, but may also help minimize your risk of developing colon cancer. The single most significant and modifiable risk factor for colon cancer in people with ulcerative colitis or Crohn's disease is active inflammation within the colon. Risk of colon cancer has clearly been associated with more severe inflammation, more extensive colon involvement, and the length of time a person has had active disease. And although the length of colon involvement and an age at which a person is diagnosed with IBD are not under anyone's control, managing active colon inflammation effectively is the most important way to minimize colon cancer risk in IBD. While this can certainly be easier said than done in a variety of instances, it is vital that patients and their physicians work towards identifying a regimen to minimize or remove inflammation completely and maintain this regimen to prevent inflammation from returning if possible. Patients should work closely with their physician to identify an individualized and effective medical regimen with the goal of not only improving symptoms, but also decreasing or completely abolishing colon inflammation. Once this regimen has been identified, patients need to ensure they continue to take their medications as prescribed, importantly again, even when you're feeling well, to minimize the risk of the inflammation returning. Additionally, treatment adherence also serves other functions, including improving inflammatory bowel disease symptoms and decreasing the risk of disease flare or disease progression in the future. So what about treatment adherence? So what is treatment adherence? This is patients doing their best to take medications as prescribed and communicate with their physicians and getting labs as directed by their physicians to make sure their treatment plan is going accordingly. And treatment adherence can be difficult over a long period of time for patients. In addition to remembering to take medications, sometimes multiple times a day, emotional, social, and financial problems can also affect adherence. Studies have shown that people with mild disease and those without good social or emotional support are less likely to adhere to treatment. Ways that you can help improve your treatment adherence are to simplify the regimen by removing medications that are no longer needed or effective, finding social and emotional support through family, friends, or support groups, staying well informed by communicating with your physician or accessing trusted resources such as the CCFA, and openly discussing concerns, problems, or new treatment options with your physician. As mentioned previously, one other way that colon cancer risk may be minimized is through chemoprevention. What is chemoprevention? Well, chemoprevention is the use of certain medications, vitamins, or other agents to potentially decrease the risk of cancer or dysplasia. There are a variety of medications and vitamins that have been studied as chemoprevention against colon cancer in both the general population as well as in patients with IBD, and we'll discuss a few of those here. Importantly, if these agents are used, it should be under the direction of a physician, and they should not at all take the place of standard medical therapies to control inflammation or regular surveillance colonoscopies. Also, while the term chemoprevention typically refers to additional medications or supplements on top of standard IBD therapies, as we discussed previously, the most important chemoprevention comes from identifying an adequate treatment regimen to control your inflammation. The first agent we'll discuss is aspirin and the nonsteroidal anti-inflammatory drugs such as ibuprofen and naproxen. Aspirin and NSAIDs have been the most studied agents for use as chemoprevention of colorectal cancer in the general population and have been shown to reduce the incidence of adenomatous polyps in this population through a variety of protective mechanisms. All these medications are very commonly used in the household and do appear to be effective as chemoprevention in the general population. They have the potential for very serious side effects in some patients, such as gastric ulcers, gastrointestinal bleeding, and kidney dysfunction, and should only be used as chemoprevention under the direction of a physician. Importantly, in reference to inflammatory bowel disease, aspirin and NSAIDs have not been studied for chemoprevention in people with IBD. Unfortunately, use of NSAIDs in IBD has been associated with a potential risk for disease flare, and therefore their use as chemoprevention in this population is limited. Generally speaking, NSAIDs should be avoided among IBD patients if possible. Folic acid is another chemoprevention agent that has been studied in both the general population as well as IBD. In the general population, studies have shown an inverse relationship between dietary folic acid intake and colorectal cancer risk. Specifically, deficiency in folic acid has been associated with an increased risk for colorectal cancer, and high folic acid intake has been associated with a decreased risk of colorectal cancer, suggesting supplementation with folic acid may be beneficial as chemoprevention. Conversely, studies looking at the benefit of high folic acid intake on colorectal cancer risk for ulcerative colitis and Crohn's disease patients have been mixed. Some studies suggest a decreased risk with folic acid supplementation, while others do not show any significant benefit at all. However, since folic acid supplementation is safe and there appears to be at least a possible benefit for decreasing colon cancer risk in IBD, folic acid can be used as a chemoprevention agent in patients with ulcerative colitis and Crohn's disease. Likewise, medications specifically used to treat ulcerative colitis and Crohn's disease may also help prevent colorectal cancer. There's a variety of medications we use to treat IBD, and the medication class that has been most extensively studied for chemoprevention has been the 5-ASA or morphoxamine compounds, and these include things like sulfasalazine, Asacol, Lialda, among many other medications. In addition to their primary treatment effect to manage inflammation in mild to moderate ulcerative colitis, 5-ASA compounds may also decrease colon cancer risk, although the results are somewhat mixed. While older studies seem to show a clear benefit in decreasing colon cancer risk with use of 5-ASAs, more recent studies have not shown the same benefit. Because we know that controlling inflammation is the most important factor in decreasing cancer risk, it is possible that differences between older and newer studies here are due to more recent improvements in both our ability to treat inflammation with newer and more effective medications, as well as closer monitoring to ensure we achieve mucosal healing and in fact heal the inflammation as opposed to just improving symptoms. Even though the absolute benefit of 5-ASA medications purely for decreasing colon cancer risk is somewhat unclear here, these have generally been recommended for chemoprevention in IBD. Lastly, ursodeoxycholic acid is a bile acid supplement that is frequently used in patients with certain liver diseases such as primary sclerosing cholangitis or PSC. While there's been a large interest in the past looking at the use of ursodeoxycholic acid for the treatment of PSC-associated liver disease, it has also been studied as chemoprevention against colon cancer among PSC patients with ulcerative colitis. The majority of PSC patients, in fact, do have ulcerative colitis. Similar to other agents, the results have been somewhat mixed, unfortunately. Generally speaking, the use of low-dose ursodeoxycholic acid and what constitutes low dose has changed over a variety of different studies, may decrease the risk of colon cancer among PSC patients. And high-dose ursodeoxycholic acid has not been shown to be effective for chemoprevention. Again, what constitutes high versus low dose has changed depending on which study you're looking at. Importantly, while ursodeoxycholic acid may be used as chemoprevention in patients with PSC, it is generally not recommended for IBD patients without PSC. So, in summary, although people with ulcerative colitis and Crohn's disease are at higher risk for colorectal cancer, cancer is preventable and treatable when found in its earliest stages with over a 90% survival rate. It is important for people with IBD, one, to recognize that they are at increased risk of colorectal cancer, and then take measures to reduce this risk whenever possible, particularly in ensuring adequate control of their disease and maintaining treatment adherence to medical regimens and surveillance colonoscopy programs to identify dysplasia or cancer early and manage it effectively. Screening and surveillance are keys to prevention here. And if you're looking for more information on colorectal cancer and IBD, you can contact your physician or visit the CCFA's fact sheet at the website listed here. And that concludes my presentation.
Thank you, Dr. Fendamore, and all our presenters for today's program. You've really offered great expertise and helpful information for patients and caregivers, so we thank you. The Crohn's and Colitis Foundation of America offers a comprehensive array of services to patients and caregivers touched by inflammatory bowel diseases. The Irwin M. and Suzanne R. Rosenthal Inflammatory Bowel Disease Resource Center, or IBD Help Center, is here to provide information, support, and guidance to help you manage your disease and take charge of your life. You can call or email our information specialists to ask questions, obtain helpful resources on IBD, and the IBD Help Center is available Monday through Friday, 9 a.m. to 5 p.m. Eastern Time at the information shown below. You can also participate in local events, obtain disease-specific publications, and engage via virtual education such as this and other webcasts, videos, and social media. And know that you are not alone. Connect with others to support through participating in CCFA peer-to-peer programs, engaging through online community discussion groups, and learning more about our Camp Oasis program for children with IBD. We also offer a variety of online resources to help patients and caregivers with disease management, including our I'll Be Determined website, GI Buddy app, teen and young adult websites, and also connect and learn about your disease through these age-specific websites. You can learn more about all of these resources by contacting our IBD Help Center at the information shown below or by visiting our website. If you are looking for fun, family-friendly activities to raise mission-critical funds for CCFA, sign up for our Team Challenge, full or half marathons, Take Steps Walk, or our new Spin 4 programs near you.
All right, our first question comes from Kyle, and his question is, I have UC but have had a total colectomy. Am I still at increased risk for colorectal cancer given the small amount of tissue required to be left for my J-pouch creation and reattachment after ileostomy?
Yeah, I can take this one. I think, unfortunately, with the residual rectum that's in place, that risk of cancer developing in that tissue still does remain. And a lot of that, kind of what that risk is, depends on how much of the rectal tissue is left that this pouch was sewn into. And how often to survey that, there's not a whole lot of great guidelines on how often we should be looking at those areas, but I generally in my patients do survey those every few years just to make sure there's been nothing that's developed.
Great, thank you. The next question is from Abby, and she asks, if you are in remission of UC, meaning no flares or many symptoms for a long period of time, is your risk still heightened to develop colorectal cancer?
I would say that controlling disease is definitely and helps with decreasing the risk of colon cancer. I think anytime you've had that history of colitis, you are at a heightened risk, but the degree of inflammation that was there, the amount of your colon that was involved, and how severe that inflammation was also is a factor in that risk. So the better your disease is controlled, and for the longer period of time, the lower your risk is. Right now, our guidelines don't make that then change how often you get your colonoscopies, but I think it overall puts you at a lower risk than a person who has severe inflammation that continues on without being controlled.
Great, thank you. Our next question comes from Sarah, and her question is, many of the symptoms of colorectal cancer are the same as the symptoms we experience on a daily basis with having UC or Crohn's disease. So what is the best way to look out for what could be colorectal cancer-related symptoms versus what is everyday IBD-related symptoms?
It can be very difficult to identify. I agree that many of the symptoms are very similar, and so that's why it's very important to begin colonoscopies for surveillance after 8 years and keep up to date with colonoscopies, because it can be really very difficult to differentiate symptoms of IBD and symptoms related to colon cancer. There aren't often clear differences between the two. So keeping up with colonoscopy and having a really high quality bowel preparation so the colonoscopy is really the highest quality exam possible is really important.
I agree with Dr. Flynn that I think the kind of real key here is that we're doing proactive exams on patients before they have any symptoms that might suggest cancer to try to prevent cancer from ever happening in the first place.
Great, thank you. And we have another question from Sharon, who's asking, if a colonoscopy biopsy shows indefinite for dysplasia, when is it recommended to repeat the colonoscopy? And other recommendations, how long could it take for indefinite for dysplasia to possibly turn into cancer?
Yeah, that's unfortunately a really difficult question to answer because, as the name suggests, indefinite for dysplasia leaves us kind of questioning whether there's dysplasia there or not. And we'll often see that as an early stage, very kind of early stage of dysplasia that will then progress. But sometimes we see those changes that are just in the setting of active inflammation, and it just confuses the pathologist as they're looking at the slide. Absolutely, I think patients who have indefinite for dysplasia should be screened more closely, and often I'll repeat an exam within 6 to 12 months, usually about 6 months, and try to get the inflammation under control before we repeat the exam if that's what's going on, so that we don't have any of those factors that are affecting our ability to look at the biopsies and see if we pick up anything else new. As far as how long it takes to turn into dysplasia, that's difficult to tell, but I certainly think the finding of indefinite puts us at heightened awareness that there's a potential there that something bad could occur.
Yeah, I agree completely. Very often, your doctor will recommend either a course of steroids or some change in medical therapy to really optimize control of inflammation if there was inflammation there during the exam, and then schedule a repeat, procedure sometime between, maybe 6 weeks and 6 months, but, depending on what was seen during your procedure.
Great, thank you. Another question is from Bonnie, and it is there any evidence that the process of colonoscopy or use of chromoendoscopy can result in a flare?
There's no evidence that a bowel preparation or undergoing a colonoscopy or taking biopsies, removing polyps, or performing chromoendoscopy increases the risk of flare of inflammatory bowel disease. So we don't see evidence for that.
Great, thank you. Another question is from Alan, and he asks, does the risk of colon cancer increase with increased disease activity in UC patients?
That does. If you look at some of the finer risk factors of colon cancer in UC patients, some of them would be how much of your colon is involved, how severe that inflammation is, and so the amount or the severity of inflammation does play a factor, in addition to having a family history of colon cancer or having primary sclerosing cholangitis all kind of play into that.
Great, thank you. I believe, Anne, you had mentioned this in your presentation, but someone's asking, what is the best prep for a colonoscopy?
Well, there's several factors that go into a bowel preparation, and typically your doctor will work with you to select, the bowel prep that's right for you. Your doctor might, review your other medical problems, and that might factor into selecting, the bowel prep that's right for you. So I would talk to your doctor about it. It's helpful to write down bowel preps that you've gotten in the past. If you've had trouble with nausea or vomiting with a particular preparation, then a good idea to let you know, what happened last time. But really having a conversation, and this can be an individualized discussion with your doctor to choose the best prep for you individually.
I think a lot of patients are looking, rightfully so, for that kind of easy magic pill to take that's going to clean them out with kind of minimal effort and having to drink a terrible tasting bowel prep. It turns out the large volume preps that we prescribe do the best job of cleaning people out. And certainly some people can't tolerate those, and so we can tailor different preps to different patients. But that's the reason why we use those as kind of first line, is because they seem to do the best job for patients.
And I think the last thing to highlight is that the quality of the exam really does highly depend on how well the clean out's able to be. So, so to get the most information out of these exams and the most helpful surveillance biopsies or chromoendoscopy look, the better prep is really by far the best.
Thank you. Carrie has asked, if my Crohn's disease is located in my small intestine, am I still at heightened risk for colorectal cancer?
That not if it's just in your small intestine. So the risk of colon cancer with Crohn's disease links to the amount of inflammation that's in your colon. And so if your Crohn's disease has only affected your small intestine, then your risk of colon cancer is the risk of the average population.
Great. The question is, what kinds of circumstances would lead an endoscopist to decide not to remove a precancerous tissue?
Yeah, as I had mentioned in my part of the presentation, a lot goes into how to manage dysplasia when we find it. And so I think some of it has to do with the endoscopist's comfort level and being able to take out a polyp, how big the polyp is, if we can clearly see the borders, and whether or not we can actually physically take it out if it's small enough to do so. And all those things kind of play in. So, sometimes we're not exactly even sure if an abnormal area is even dysplasia in the first place, and in which case the first step might just be to take biopsies to establish that it's dysplastic in the first place.
And some gastroenterologists have special training in removing large or difficult polyps, and so there may be a situation where your doctor, takes a look and finds an area that's concerning, and he or she might send you for another exam by a specialized, doctor who might feel more comfortable taking out that area.
Great. We have a question from Jackie asking, if you had symptoms of Crohn's disease for many years before being diagnosed, should your screening begin 8 years after the beginning of symptoms or 8 years after diagnosis?
Yeah, I think generally speaking, if I can clearly identify patients that had obvious symptoms of Crohn's or ulcerative colitis many years before we diagnose, I'll often start the time clock when those symptoms started as opposed to when we actually made the diagnosis. Sometimes it's a little bit hard because previous symptoms don't kind of align with what their actual symptoms are now, and so in those instances we'll use the time of diagnosis. But if it's very clear that they've had the same symptoms for many years, I'll start the clock earlier.
Great, thank you. A question about screening. How do you screen for primary sclerosing cholangitis? Is this dysplasia?
So primary sclerosing cholangitis is when you can have inflammation up in your bile ducts, which is where the bile drains from your liver down into your intestines. So it's a separate condition than ulcerative colitis, but linked in that many people who have primary sclerosing cholangitis also are found to have ulcerative colitis. So there's a relationship. It's not dysplasia, but people who have sclerosing cholangitis are at a higher risk of forming dysplasia in their colon. The way that it's found typically first is just by seeing that your liver tests look abnormal, and a doctor might decide to investigate that further. And the way it can ultimately be diagnosed is by doing some extra imaging tests of your bile ducts, typically done really just if your liver tests are persistently abnormal and your doctor starts looking into that.
Thank you. I have a question here from Karen asking, I am a 60-year-old woman with UC controlled with medication. Are there any alternatives to annual colonoscopies? And some examples included were capsule with camera, etc.
Yeah, I think there's a number of different modalities or imaging studies that have been coming out in the general population to look for polyps, like colon capsules and CT colonographies and these types of things. And I think it's important to know that none of those newer imaging studies have been studied in inflammatory bowel disease. And unfortunately, in IBD, often dysplasia grows in a more subtle fashion that I think could easily be missed. I mean, it's even, unfortunately, sometimes easy to miss when we're looking at it directly with a colonoscopy. And so if you're trying to use something like a capsule or CT scan, I think it would be much easier to miss on those studies. So it's certainly not recommended right now, and I'm not sure that it will be recommended in the future.
Great, thank you. We have a question from Lisa asking, does having hemorrhoids count as having active inflammation? The diagnostic colonoscopy was clear when looking for what was causing symptoms, so she's wondering if that is part of the consideration for inflammation.
No, usually we wouldn't consider finding hemorrhoids to represent active inflammation in the colon.
Okay, thank you. Another question is, if there is inflammation in the colon, do I need to reschedule my colonoscopy and wait for colorectal cancer surveillance until my colon is not inflamed?
There's several reasons that we do colonoscopy, and colonoscopy is really important to evaluate whether medications are working or whether changes in therapy are needed. And so if you have a colonoscopy scheduled to look and see whether your colon is healed or inflammation is improved on a therapy, then I think you should go forward with that colonoscopy. It may be that if you need some other changes in your medicines to really better control inflammation, then your doctor may decide to do that dysplasia surveillance at a later time. But if you're someone who's had disease that's been very difficult to control over time, then your doctor, may do the dysplasia surveillance at that time. So, no, I don't think your colonoscopy should be rescheduled necessarily because of active inflammation, but you should really talk with your doctor about, what you're looking for during that procedure and what the goals are for that test.
Yeah, I think in an ideal world, every time we do colon the dysplasia surveillance, the colon will be very well controlled, or the inflammation will be very well controlled, but we can't always achieve that. And what I would hate to happen is somebody kind of keeps postponing their procedure until they're controlled, and that never happens. And so they don't get the appropriate looks inside to make sure there's nothing abnormal going on.
Great, and we have time for one last question. And this question's from Sally, if the colon appears normal during the colonoscopy, but biopsies show inflammation at the molecular level, does this pose the same risk as if the colon was visibly inflamed?
Yeah, I think it's really, we've said a number of times, I think that inflammation clearly is associated with an increasing risk of dysplasia, but what level of inflammation constitutes an increased risk, I don't think it's clearly been established. I absolutely think that if you see inflammation just on biopsy and everything else looks normal, then that's not the same as seeing very severe inflammation both by endoscopy and on biopsy. So I don't think they carry the same risk, but what the difference in those two risks are, it's hard to say.
Okay, actually, let me just ask this one last question. So this is from Jana, and her question is, since some IBD treatments are actually similar to chemotherapies, would they also help reduce the risk of developing colorectal cancer as well as help with IBD inflammation?
I think I guess I would say the only impact we would know they would have is if it controls the inflammation, and so sort of tying it back to the process of inflammation leading to cell changes, leading to dysplasia, and if that therapy is controlling their inflammation, then thereby decreasing the risk. But there's never been any proven evidence to say that some of those chemotherapy medications have some additional benefit in decreasing the colon cancer risk.
Great, thank you. Thanks to all of you for this wonderful presentation. I want to ask our participants for today's program to please click on the bottom widget of the screen. You will find an evaluation. The widget is a green icon. There you will find a link that will take you to the evaluation, and we appreciate everyone's feedback as we plan for future programs. So please include that information. I also want to remind everyone that the program will be archived and available within 2 weeks of today's program, and you will be notified once that archive is made available, and it will also be posted on CCFA's website. I also want to encourage that if anyone has any additional questions on colorectal cancer or any other IBD-related questions, please reach out to our IBD Help Center. You can call us toll-free at 888-694-8872. You can use an online chat by visiting our website at www.ccfa.org, or you can also email us at info@ccfa.org. We appreciate your attendance at tonight's program. We thank you and have a great night.